Welcome, welcome, welcome. This is Healthcare for All Washington's second Wednesday speaker series. Thank you for joining us. I'm Ronnie Shure. I volunteer as president of the board of directors of Healthcare for All Washington. I spent most of my career as a pharmacist in local public health departments, where I saw the infrastructure that was needed to provide the essential services from infectious disease to reproductive health to environmental health. And I saw innovative programs addressing these social determinants of health and helping to build these important infrastructure for our community. I spent several of those years in the Tuberculosis Clinic in public health here in Seattle and King County. And that's where I got to know Stefan Goldberg. Tonight's a pleasure to welcome him back here virtually for a discussion about the public health of our community. Thank you for joining us tonight. Just like me, you also can volunteer for Healthcare for All Washington. Please consider doing that. You can volunteer on one of our committees, our policy or communications or fundraising or outreach, or as an alternative to an ongoing opportunity, we welcome you to join us for a specific project or two, or just be volunteer to offer us advice on planning. Uh, in this Zoom meeting, if you go to the chat button, we will be posting a link to our website, and that's how you can get involved. You will find the donate button that'll open up the website. You can go to a button that says get involved, that gives you some volunteer opportunities, entering your personal information, which we won't share outside. And if you're able, please make a donation. Every donation helps us move a step closer on the pathway to universal health care. We have set a goal to raise $250 during this meeting tonight. So go to the chat at any time during this presentation to make a donation, or push the button to get involved. We will be adding resources from tonight as well as the ongoing information there. So please check out our website. You'll see our goals and our long-term vision and strategies to move along the pathway to create to transform our marketplace healthcare program to a true healthcare system with everybody in and nobody out. There's a lot of reasons to look at our website, so please do that. And while you use the chat, that's where we're going to be tracking any questions that you have. So we will answer those questions after Stefan finishes his presentation. So hang around, don't leave right away, but please enter your questions in the chat and just hit on that button at the bottom of your Zoom screen that says chat and edit. You also notice there's an option at the bottom of your screen for AI or closed caption. I think most of our Zoom screens say CC for closed caption, and then you can enable those captions to show up on your computer. I am participating in this Zoom meeting tonight from the lands of the Coast Salish peoples. Please take a minute to acknowledge the people in the lands where you are joining us from today. We met someone a little while ago from Massachusetts who's joining us. We acknowledge all of the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Unlike our current national leaders who are ignoring history, ignoring lessons we've learned from our ancestors, we respect the efforts of the leaders of those indigenous peoples who continue to teach us today to remember those lessons, those life lessons, and to preserve the lands. We thank the Coast Salish peoples of this land, the land where I'm coming from, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So, Ron, if you could bring up Stefan, let me introduce him. He worked on the front lines there we go, in the tuberculosis clinic where I was for a while at Public Health Seattle and King County. He was here from 1991 to 2003 and then moved to Atlanta to the Centers for Disease Control and Prevention. He worked in the Division of Tuberculosis Elimination from that time, from 2003 until 2017. He is an adjunct assistant professor at Emory University's Rollins School of Public Health. And he's a professor in the Department of Epidemiology from 2015 until the present time. He's served on the board of the Treatment Action Group since 2024. TAG, this organization, envisions the end of HIV, TB, and hepatitis C. We would like to recognize and I hope, Stefan, you'll take a few minutes to describe your work, your commitment there. And I think we'll see that through this presentation. We will be glad to share a list of the dozens of publications that come from Stefan's research, but tonight he will be sharing a bibliography of sorts from works that has inspired his contributions and his job. So thanks for joining us, Stefan. I will open up the slides.
Great. Well, thank you, Ronnie, for that introduction, and it's great to be back with you since we started working together back in about 1991 in Pioneer Square at the TB clinic, and then moved up to Harborview Hospital when the TB clinic moved there. Thanks for the introduction. You outlined my background, I think, really well. Regarding Treatment Action Group, I recommend that everybody take a look at the website, treatmentactiongroup.org. In particular, Research and Action Award event is coming up on October 20. It's going to be a gala event, and it's awarding Jean Marazzo in particular, who most people on this group probably have been following in the news. She succeeded Anthony Fauci as director of NIAID, and she recently was fired very publicly for speaking up for scientific integrity. And that's one of the missions of TAG. And not to go into it much more here, I recommend that people on the call take a look at the website. So longtime interest for me has been the importance of literature for public health, especially TB. So that's the content of this presentation. I'm responding partly to the year 2000 Institute of Medicine report on TB elimination in the US. Still slide one. Slide one still. The Institute of their report, Ending Neglect, and that's my favorite title for a TB book. And I'll also be talking a little bit about Lee Reichman's 1991 essay, The U-Shaped Curve of Concern. Although I'm using John Green's title, Everything is Tuberculosis, I'm using it against Susan Sontag's aversion to illness as metaphor, as she wrote in her 1977 book of that title. And I'll invite some discussion on this point, the idea of using illness as metaphor, which I'll be doing some during this talk. And I'm using Victor Hugo's book, The Hunchback of Notre Dame, as a non-illness example for raising public awareness and political will. These have been themes of my consumption conversations with casts of Moulin Rouge, the musical, since one of my daughters, Tamrin, started performing with it in 2022 on tour, and this year on Broadway. Okay, now slide two. John Green wrote Everything is Tuberculosis, getting that title from his son, who asked him one day while he was working on it, why is everything that we talk about, all these events in history, cultural events, things that have been made, how do they all relate to tuberculosis? Everything seems to be tuberculosis. So in a very concrete way, he took that as the title of his book. And examples are important. World War I, for example, was in a sense triggered by TB when Gavrilo Princip, 19-year-old Serbian nationalist who was dying of TB and didn't have much to lose, shot and assassinated Archduke Franz Ferdinand at close range. Gavrilo Princip, of course, was arrested right away. He ended up dying a very few years after that at Terezin, which became Theresienstadt during World War II. But the American Revolution was started also in a sense by TB in an opposite way when John Parker, the mature captain of the militia, had laryngeal TB, and he was unable to stop the first shot on British soldiers who were marching by. He told his men to hold their fire, hold their tempers, but one of them was unable to do that and shot the first shot of the American Revolution. In 18th and 19th century Europe, 1 in 5 deaths were attributable to TB, probably largely as a result of the crowding and conditions of the Industrial Revolution. Near the end of the 19th century, during the last half of the 19th century, several books and operas were written that were inspired by TB, and the current movie and musical Moulin Rouge came directly from La Bohème and La Traviata, and those two came directly from the books, Scenes of Bohemian Life and The Lady of the Camellias, which where the authors of those books were inspired by young women that they knew personally, who each died young of tuberculosis, Lucille Louvet and Marie Duplessis. So these were real people behind these works of art. So Moulin Rouge, the musical, is about truth, beauty, freedom, love, and tuberculosis. It's the story of a young woman at the beginning. She's dying. She's sick with TB. In the middle of the show, she is sicker. And then at the end, she dies of it. Of course, a lot is built around that. The cast of the musical in the touring company worked with my daughter, Tamron, who's in the middle here, on a campaign using Moulin Rouge, the musical, to raise awareness of TB, and they became champions, CDC US TB elimination champions in 2023. Tamron has sat in the audience a few times, a number of times, and she's always been surprised by or impressed by comments that she hears. In the musical, one character says, "Oh, my goodness, you have consumption," finally recognizing the illness of his lead performer. But in the audience, people whisper to each other, "Consumption, what is that?" They're not aware that consumption at that time was another word for tuberculosis. And then another thing that Tamron hears often is this question: is TB still around? Next slide. So Susan Sontag wrote this book, Illness as Metaphor, in 1977, and I have often used illness as metaphor, but I do have this question: should we use TB as a metaphor for public health or for other social and political problems? The essay, the book itself is an essay on morality and linguistics, and she writes, "My point is that illness is not a metaphor, and that the most truthful way of regarding illness and the healthiest way of being ill is the one most purified of, most resistant to metaphoric thinking." Next slide. One author that she writes against is Albert Camus, who wrote The Plague shortly after World War II, which is the story of bubonic plague overwhelming a small city in Algeria. And it always has impressed me because of its metaphoric power. At the very end of the book, Ryu, the doctor in the story, makes a statement that is one of the most powerful conclusions to a modern novel. Ryu knew that the plague bacillus never dies or disappears for good, that the day would come when, for the bane and the enlightening of men, it would rouse up its rats again and send them forth to die in a happy city. A little bit earlier in the book was a long monologue by one of the characters named Taru, who had been motivated to care in a general sense by his own disgust with the death penalty. And he said to his friend, "It's up to us, so far as possible, not to join forces with the pestilences." Next page, next slide. The Notre Dame Cathedral in Paris was desecrated during the French Revolution in the 1790s. And then in the early 1800s, it was planned for demolition. Somehow Victor Hugo learned about this. He might have been recruited for this project, but he wrote The Hunchback of Notre Dame specifically to save the cathedral. And the great popularity of that book inspired public interest and the political will to preserve Notre Dame Cathedral and the other Gothic cathedrals of France. I've spoken both in the class I help teach at Emory and in the consumption conversations about the desire to have something like this specifically for tuberculosis, and have wondered if Moulin Rouge, the musical, might be that opportunity. The administration, the management of the company has been a little bit resistant to that. They've been supportive up to a certain point, but we haven't been able to get a flyer about tuberculosis into the program yet. So when I started working at the TB clinic in the early 1990s, this was the first book I bought about tuberculosis to learn about it. It was published in 1952 at the beginning of the era of effective antibiotic treatment. So at the time this book was being written and up until the time it was published, there was no effective antibiotic treatment for TB. And the authors, René and Jean Dubois, wrote how understanding tuberculosis demands that the impact of social and economic factors on the individual and society be considered. They wrote about tuberculosis as a social disease, and they recommended attention to social organization as a primary element of approach to TB. And beyond antibiotics even now have their limitations. So focusing on the social elements remains pertinent. And this is a book that I often recommend, both as a wonderful piece of literature and as a great introduction to tuberculosis prior to the antibiotic era. In particular, it has an excellent section on the Romantic era, and it's often cited by other writers of TB history. At the near the end of the 19th century, Robert Koch, who's in uh, the print on the side of this slide, as Saint George defeating the dragon being the tuberculosis bacillus, and in his hand he's holding a syringe that is labeled the microscope. So he's bringing science to TB, and he demonstrated using the germ theory of disease that a particular microbe is the cause of TB rather than genetics or a miasma, which were still very common beliefs at that time. But he gave a demonstration in 1982 that essentially convinced the scientific world that the particular germ, M. tuberculosis, is the cause of the disease, and that led to the discoveries that were able to really bring a cure for it. But there was a general social attitude then of optimism in science and reason, and this book, The Remedy, describes how that is shown both in the lives and work of Robert Koch and of Arthur Conan Doyle with Sherlock Holmes, emphasizing that science and reason were the legitimate ways to solve the problems of society. Next slide. So from about that time on, as some of the problems of the Industrial Revolution were addressed, hygiene was improved, living conditions were improving. So gradually TB incidence and death rates diminished through the early part of the 20th century, and then were accelerated greatly accelerated, of course, by the advent of effective antibiotic use. And this decline continued until the mid-1980s, when there was a plateau and a historic resurgence in tuberculosis. That's on the left side of this graph. This historic resurgence has been attributed both to HIV, which has a synergistic effect with tuberculosis. Each one makes the other worse, essentially, and a breakdown in public health infrastructure. The curve was returned to a downward slope by a massive reinvestment in tuberculosis control and intention toward elimination in the early 90s. And since then, the case rates have declined steadily, with a notable dip during COVID that's probably attributable to both underreporting and some of the infection control measures developed for TB as a respiratory pathogen and implemented for COVID on a much larger scale, but probably having some effect on TB. After a couple of years, the number of cases returned to a point that's consistent with the downward slope. But then the last couple of years, the case numbers and rates have been rising well above the point one would have expected, except for the COVID dip. And the point I show in red is the 2024 case number, which CDC posted in March of 25 with preliminary data, but they only post the final data for the year typically in November of each year. So those haven't come out yet, and there's not an updated slide yet that would typically come out in November. Next slide. So I looked at that website. I looked at that website to get more detail that I'll show in the following. But what really jumps out is this banner. And in the first and second line, you can see mission critical activities will continue during the Democrat-led government shutdown. And the banner also implies that the data that are shown here might subsequently be influenced with a non-science-based effect. Okay, next slide. So in the data that were put up in March, 3 things jump out related to age in particular, which is what I'll highlight here. For all jurisdictions from 23 to 24, there was an 8% increase in the number of TB cases. For Washington State, it was 17%. But then look at the age group for the country for 0 to 4 years, there was a 16% increase. And what's interesting here is that based on the social circumstances of very young children, when a young child is diagnosed with TB, presents sick, and is found to have TB, usually that means that there's an undiagnosed adult out there. So seeing an increase in TB cases among the youngest children suggests that the numbers of new cases will continue to increase. So this is a sign of a growing epidemic, forecast for a growing epidemic. And then the next point I'd like to highlight is the 2 groups from age 15 to 44 with 11 and 16% changes each, increase each. And the importance here is that a large proportion, globally it's most, of the persons who are diagnosed with new TB, who develop new active tuberculosis, are working age adults. So there's a tremendous economic impact from the disease as a result of that. Next slide. So in 1991, Lee Reichman described in a journal editorial accompanying another article the U-shaped curve of concern. And to me, this is one of the most important essays in the TB, in the US at least, TB literature. So the technology for diagnosis, treatment, care, and control are easily available, but they require more than just the drugs. And when support for all of these things is removed, case rates rise and increased disease spread occurs. This is the second U-shaped curve of concern slide. And Dr. Reichman wrote, first, evaluation indicators of a public health program show improvement leading to diminishment of compelling need, of the impression of a compelling need. Then resources providing fuel and direction for the program are removed. Finally, the incidence of the disease controlled begins to rise in proportion to the diminished resources. This phenomenon has been called the U-shaped curve of concern. And he had first used that phrase in a 1972 presentation. But this article, the U-shaped curve of concern, remains, I think, an important focal point for us in TB and public health in general. Next slide. So he was commenting on an article by Brudney and Dobkin, Resurgent Tuberculosis in New York City, HIV, Homelessness, and the Decline of TB Control Programs. And from data in their paper, Reichman created a curve to show their data that has the same shape as the US curve for that same year. And in his essay, he writes that their experience is so bleak that at first reading, one might mistake it for a theoretical worst-case scenario. And I think that has some resonance for some of the experiences that we're having today in society in the United States, public health and society. Next slide. In the year 2000, Reichman and another leading TB researcher, Earl Hirschfield from Canada, co-edited Tuberculosis, a Comprehensive International Approach. This was the second edition of a major textbook on TB. And they wrote in their introduction, the year 1993, which was when the first edition of the textbook came out, also marked the beginning of the reversal of resurgence of TB in the United States, which was one of the greatest public health successes of the 20th century. This reversal underscored the observation that political will is the most critical ingredient in tuberculosis control. Next. The same year, the Institute of Medicine came out with this book, Ending Neglect, the Elimination of Tuberculosis in the United States. And in preparing this report, they visited TB programs around the country, including ours in Seattle. And there are a couple of anecdotes in the book describing aspects of Seattle's TB control program in the late 1990s. But they came with these recommendations. First, maintain control, the recommendations for TB, what to do. Maintain control. Number 2, speed the decline. Number 3, develop new tools. 4, increase US engagement in global efforts. And number 5, mobilize support and measure progress. These recommendations became the basis of the US strategic plan to eliminate TB, and that remained the official strategic plan of CDC's TB program, the Division of TB Elimination, at least through the spring of 2025. Next. So the final slide, this is the final slide that I will be presenting here. In Macbeth, a scene that's important to me, and I think to the work that we're trying to do, is often left out, perhaps for length, but is not included in public performances. And I have seen this a couple of times recently, but I think it's an important scene to pay attention to for quite a number of reasons. Malcolm is the son of King Duncan, who Macbeth had murdered in order to become King of Scotland. So Malcolm and his friend Macduff went to England in exile and to recruit the assistance of the King of England, Edward, to respond to Macbeth. So while Malcolm and Macduff are visiting outside the castle, a doctor comes out and explains what the king has been busy with. And specifically, the king has been touching uh, a great crowd of people with scrofula, which is tuberculosis of the lymph node of the neck. And from the Middle Ages until at least the 18th century in Europe, um, the monarch, kings and queens of at least France and England were believed to have a divine ability to heal people with scrofula. So this was sometimes called the king's disease, and their treatment was called the royal touch. And here the doctor says, at his touch, such sanctity hath heaven given his hand, they presently amend. So they heal from the touch. And indeed, some people do get better spontaneously, and it's easy to believe that they are responding to this treatment from the king. And then Malcolm explains to Macduff that he has this divine ability, and to the succeeding royalty he leaves the healing benediction. And partly this was Shakespeare sucking up to James I, his king at the time, because James I indeed practiced the royal touch and claimed descent from the King Edward, who's in this story. But the subtext here is that the illegitimate king, Macbeth, does not have this royal touch. So this scene is a comment on the illegitimacy of Macbeth while supporting the legitimacy of King Edward. So I'll stop the speculation there, and there are two subsequent slides available to look at later that include current fact sheets from WHO and CDC, describing in some more detail a little bit of key information about TB. So thank you for listening.
Well,
It's been a great opportunity for me. I've really enjoyed putting this presentation together.
thank you, Stefan. And I'm sure you're not saying that King Trump is considering himself to have the magic touch, uh, although he is trying to change the leadership that our public health experts like you have provided over the years. It's frightening to think about, the past as prologue, something that you shared with me, which Shakespeare shared with all of us. So thanks, Stefan. I think you've raised some thought. Let's add your questions in the chat, and shortly John and Stefan will come back with to answer those questions. I think John's here. Did John?
Yeah, I'm here. Yeah, great. Thanks.
Good, good, good,
And
good. So take your time. Just wait a minute. So if you and can come back on in just a few minutes, I'd like to introduce Peter Lucas from Bainbridge Island, who is the treasurer for Healthcare for All Washington, to talk to you about how to donate. Right, Peter?
That's what I'll do. Can you all see me and hear me okay?
Yep.
Good. Well, I want to thank you, Dr. Goldberg, for your wide-ranging presentation that wove together many threads such as epidemiology, social determinants of health, politics, history, and literature. Wow, to get all that stuff into one presentation really says something. Our organization, Healthcare for All Washington, has supported legislative action since we were established in 1994, including the Washington Health Security Trust, which is a bill that we wrote to create a single payer system in our state. And we also helped create the Universal Healthcare Commission, which is meeting now in an ongoing manner, and we continue to be active participants in its mission to establish a proposal for universal health care in our state, and we advocate strongly for it to be a single payer plan. Our professional lobbyist, Lonnie Johns Brown, as well as our board members, volunteers, supporters, communications specialists, maintain close contact with legislators, providing education and guidance in drafting bills and enlisting allies in Olympia. And we've been involved in the creation and enactment of many progressive healthcare reforms over the years. In the process, we've been very fortunate to forge strong bonds with many Washington state legislators who support our mission and work to bring it to fruition. In addition, we educate the public about universal health care and other aspects of health via our outreach and media activities, such as monthly webinars like tonight. Now, these don't come free. They require financial support in terms of personnel, outreach efforts, and administrative support. So that's where you come in. Please help us continue this work by making a donation tonight. We've been peppering the chat with links to donate throughout the course of the evening. So please click on them and make a donation. And we really appreciate, especially continuing monthly donations. They help sustain us throughout the year. And we certainly appreciate your past, present, and future support. And we believe that together we can achieve cost-effective, high-quality universal healthcare coverage in Washington State. So thank you so much.
Well, thank you, Peter. So, John is another member of our board of directors, retired OBGYN who has been a part of several aspects of healthcare system. And John has been reviewing the chat. And so if you bring Ron, if you could highlight Stefan, let's take me off and let John and Stefan handle these questions.
I want to say great, and thanks, Dr. Goldberg, for your presentation. And I spent a lot of time at Harborview between '88 and '93, and you probably know a good friend of mine, Peter Shallett, since you guys probably overlap circles. But even in medical school in the '80s, late '80s, early '90s, and residency, I didn't see a lot of tuberculosis, but I did an internship in Harbor UCLA. And in July, the first patient I watched actually bleed to death of sanguinate was from a cavitating tuberculosis lung lesion in the ICU, and hadn't really seen that much. So, I think I grew up in medical school thinking tuberculosis was an old disease, but I got a pretty quick awakening that it was still a pretty current concern. The questions we have so far, question number one was that chart you showed about the cases in the different age groups. And question number one was, given the uptick in cases in the 0 to 4 group, is there an indication to change from targeted to universal maternal screening during pregnancy, or is it not deemed cost effective? Hepatitis B vaccine, for example, in infants changed from targeted to universal in the early 1990s.
I guess this is referring to targeted versus universal testing for tuberculosis infection.
In pregnancy, right?
In pregnancy. I don't think there's an indication to treat pregnant individuals different from other groups. And I think this is the current national policy. The place to check specifically for policy is with the local county health department. But the group, tuberculosis is still an uncommon disease in this country. But if a person has a a medical or epidemiological risk factor for having TB, that person should be evaluated for TB infection if they have not already been. And if they have symptoms suggestive of TB disease, they should be evaluated for that. So if there's a risk factor for TB infection or disease, if a person is pregnant or not, a skin test or the blood test, a blood test should be done to evaluate for the presence of TB infection. And if TB infection is found, to follow that up with a chest X-ray, even if a person is pregnant, to see if there's undiagnosed pulmonary TB, because the greatest risk would be if the mother develops active TB and then passes it on to the highly vulnerable newborn. And for TB disease, finding that during pregnancy is important for the same reasons.
So I think putting the 2 points you made together is, even though it may be you could find somebody who is symptomatic or at risk for TB and test them, the overall incidence is still pretty low. So whether that makes it cost effective or not is maybe part of the question.
Yeah, not as a, I think there's a general belief that it's not cost effective to test every pregnant person for TB, but in the presence of risk factors, epidemiological or medical, those would be reasons to test.
Great, thanks. Next question. Has the U-shaped curve continued a steady upward climb since 1990, or have there been periods of decline? And I think there was a little bit during the COVID time, but other than that, has there been any other areas of decline?
There was this historic resurgence that ended with a big investment in the early 90s. So the curve has gone down. And as long as it's going down, then that's what one wants. But the return of the U-shaped curve is what I was trying to describe as something that's happening in the late COVID and post-COVID era. So the case numbers in 2023 and in 2024 show a definite resurgence of TB. So this is the return of the U-shaped curve.
Great, thanks. And here's the $64 million question. Why don't we have a vaccine for TB after so many years of TB?
That's really a very important question, and a vaccine, finding an effective vaccine would be the holy grail of TB control. BCG is the most widely used vaccine in the world, and it's used especially in young children, and it has the benefit of preventing the youngest children from developing the severest forms of disease. So it has value, especially in places where there's not an effective TB control program. In the United States, BCG was not, in recent decades, has not been recommended as a standard tool because it does interfere with the reading of the tuberculin skin test. This argument is going away a little bit with the new interferon gamma release assay tests, quantiferon, which avoid the BCG antigen, but TB is an uncommon disease here, so introducing BCG here, I don't think anybody would recommend. But it's very difficult, and a lot of immunology work has gone into trying to develop vaccine replacement for BCG. There are late phase clinical trials happening right now, and it could be that in the next couple of years we'll be seeing some promising news. But technically, they've not been successful to date.
Great, thank you. One other question just came in. You mentioned HIV and homelessness as risk factors for TB. What are other risk factors, and what effect do population disparities have on the incidence of TB?
Well, HIV, of course, is very important, and in that paper by Brudney and I'm sorry, I don't remember the names so clearly. Brudney and Dobkin, 1991, half of their patients had HIV infection. So what are some of the other immunosuppressive conditions that raise the risk of TB? Conditions that we're learning more about recently are diabetes and undernutrition. These are two that are increasingly becoming recognized as huge problems globally. But anything that's immunosuppressive increases the risk of acquiring and developing a TB. So this would be high dose long-term steroid therapy, cancer chemotherapy, having a malignancy, and then there are drugs that are used, modern expensive drugs used now that are for rheumatological conditions that suppress the body's immune response. And typically before starting a regimen like that, for example, if it's being used to treat psoriasis or different kinds of arthritis, before starting a regimen like that, people are usually advised to get tested for tuberculosis infection and to be treated if that's present in order for that drug not to activate it. And in terms of epidemiological groups that have TB, different populations that have TB, in large parts of the world, TB is highly endemic. In the United States, our rate is something like 3 per 100,000 new cases per year. But in some parts of the world, those rates are up in the hundreds, and in specific populations, 1,000 or more per 100,000. So huge rates. So for people who are coming from endemic areas where there are medium and high rates of TB, they bring their rates with them. And the likelihood of developing TB later in life comes with them.
Great, thank you.
Well,
there's another question, combine kind of two questions. One is, how much is anti-science, anti-vaccines, and all that seems to have been heightened by the mandate of COVID in 2021 is causing people to not want to get tested, vaccinating? Is any of that contributing to the rise of TB? And then I'm going to add to that, what do you see in the last year or two with the increase of pertussis, measles, and other unvaccinated diseases that worry you for the future of TB in the next year or two, in the future?
Well, first is whether vaccine hesitancy or avoiding medical care are affecting people's attitudes towards TB evaluation and treatment. I don't know. I haven't seen anything written about that specifically. I know that CDC has been involved in outbreak investigations Uh, and hearing the reports coming out of that, my impression always has been that people have been in current times cooperative, wanting to cooperate. So I'm not aware of that kind of anti-science, anti-COVID science in particular, anti-vax attitude affecting TB issues specifically.
Great,
And
thanks.
regarding whether I'm concerned about pertussis and these other conditions, yes, absolutely, it's very concerning. But those aren't my field, but I see the reports of those issues as others in this group do.
As a child who had pertussis, I wouldn't wish it on my worst enemy.
I had it as well. I remember being in an oxygen tent for about a week at Children's Hospital in Denver.
Well, thank you, Dr. Goldberg, for inspiring us to take action. To providing this information helps us to look at other diseases and our public health infrastructure. So thank you for joining us tonight. And in closing, I want to thank our volunteers, uh, Ron Lovell, Rich Legoo, Peter Lucas, John Sobeck, who you've seen or who are behind the scenes tonight, our communications committee. Remember, you can volunteer to help us, who have been reaching out to promote this event, to inform you about this going on. So thanks to Marcia Stedman and Sydney Jones and Ron Lovell, Connie Rock, John Sobeck again, Carl Thuneman and Conlin Hong, Howard Rosenfeld, and our video man behind the scene, D.W. Clark. Let us know if you'd like to volunteer for a future event or have some ideas. We need you. Next month, instead of Wednesday night, we're having our annual meeting. It'll be Saturday, November 15th at 1 p.m. We'll have a presentation from the new director of the Washington State Healthcare Authority, Ryan Moran. And then on December 10th, we'll return to our Wednesday night events. We have been talking about democratically based community health centers. It started with a couple of clinics earlier this year. Two founders of the CMAR Community Health Services are going to join us in December. So watch for that information. Thank each of you for joining us tonight. And Dr. Goldberg, I appreciate all the work you're doing for our global community. So thank you, thank you, thank you. And good night.